Today I'll talk a little bit about adductor longus avulsions in athletes. First, I'll state that I don't have any financial conflicts of interest. I am a physiotherapist, so I'm a little bit exercise biased, but I'll try to be objective in my approach. So today we'll do two main things. We'll talk a little bit about the diagnosis, how you can diagnose these adductor longus avulsions. And then we want to give a little bit of information about the different types of management, mainly surgical versus non-surgical treatment options. First, when we're looking at acute adductor injuries, we have the adductor longus muscle, as you see here in the middle, that attaches to the pelvis. Up here on the pubic bone, goes down. The majority of the injuries occur at the muscle tendinous junction. And here intramuscular in the proximal part, but also distally at the distal muscle tendinous junctions. Today, we'll focus on injuries at the proximal insertion, where the majority of injuries are acute adductor longus avulsions, or at least partial avulsions. In general, for an epidemiology overview, we can say that around 15 players, football players, will experience an acute adductor longus injury. There's quite a lot of injuries across the different teams. Any given team can expect about 3 injuries per 3 players having an adductor injury per season, per team. And the majority of these injuries will be in the adductor longus. Unfortunately, we don't have any clear overviews of how many of these injuries are adductor longus avulsions. It's my impression that we're probably talking about maybe 1 injury per 10 teams per season. So 1 to 2 injuries per league a year. So they are relatively rare. And that's why a lot of us don't have a lot of experience dealing with these injuries. So hopefully, if it happens to you, you'll be able to use this presentation and get a little bit of a better overview of what to do in these cases. We'll start out watching how these injuries can occur. You have to watch the defender here in the back, going on to the red player and making a relatively easy pass, falling to the ground. See it again. Player in the back, into the picture here. Bad touch from the striker, and a simple pass back, and he falls to the ground with an adductor injury. You can see it from another angle, getting a little bit behind him. And boom, it doesn't look too bad, but this was actually an avulsion injury. This is one of the mechanisms that can happen. We looked at adductor longus injuries in general, so we had players coming in here for treatment, for assessment, and we did a proper clinical examination on them, and then we were able to find the video footage of the match which they played in which they got the injury. And then we showed this video to the players, and they were able to pinpoint the exact moment where they felt the pain. Using that, we could then analyze these different injury situations, and we came up with 4 different groupings in the little cohort that we had of 19 players. A here on top is the change direction. In this case, it's a goalkeeper who's just pushing forward and to the side. Relatively easy save, but having an adductor longus injury here. See the player again here, extending back to make an easy pass back to the goalkeeper. So kicking injuries were one of the categories, and reaching. Here the ball is in front of the player. Player has the back foot on the ground and reaching for the ball in front of him. And then there was a few jumping injuries here also with the leg to the back as it's then rapidly moving forward into a jump. So these were the 4 main injury mechanisms. And funny enough, all of these injuries here, all of these players actually had an acute adductor longus avulsion. So there's not really one specific moment, injury situation that can tell us that this is going to be an adductor longus avulsion injury. There are some key movement patterns that we can look at though for adductor longus injuries in general. Here I made 2 little figures of 2 of the examples. The figure is actually exactly the same. The only difference is that I've placed the left foot on the ground and to the left here, and on the right side, the right foot is on the ground. But other than that, the figure is completely the same. And you can see they kind of look like the pictures here. So these kind of key movements of the hip, where we have a hip extension, have a hip abduction, and an external rotation, the hip is really putting a lot of stress on the adductor longus. So it really requires a high capacity on the adductor longus, and that can be in an open chain movement with a rapid change to direction, or more in an overstretch movement where we're reaching for the ball. Unfortunately, there's not a lot of research explaining to us where the most common injury mechanisms are. In our cohort, we could see that we had 16 athletes in as part of one of our studies. We can see that the majority were in change direction or reaching or tackle movements. So these are kind of closed chain movements, but also kicking and sprinting, which we would consider open chain movements. So again, not a clear proportion of injuries going to a specific injury situation, but different situations, and we have to be aware of all of these. In a small study on 6 athletes in Germany, mainly football players, 4 were considered overstretch injuries, but again also kicking and sprinting as potential injury mechanisms. And in NFL, different sport, where there's not a lot of kicking, we have change of direction, blocking, forced abduction on the ground, and breaking and twisting. So all here closed chain mechanisms, which is natural in a game that doesn't really have a lot of kicking. But then the player gets an injury, he comes into you got to figure out how bad is this injury. So how can you expect that this is a severe injury? So one of the things is a clear hematoma around the proximal adductor insertion, which can often extend up to the inguinal area. Here we see a player 2 weeks after injury, also with a large hematoma, which has now gone more distally and posterior, which will also indicate quite a lot or quite a high injury extent. When you see these players relatively early, as we do here usually, it is not that clear. We don't have bruising in a lot of these cases. Less than 10% of the players we saw had bruising, and less than 25% had swelling. So it's not just that clear on the initial impression. So we should ask the player a little bit more. And we did a study which is actually just out today, where we compared different parts of the clinical examination, so the history, clinical examination tests, and towards the MRI injury grading. So grade 0 being no injury on the MRI, and grade 3 over here being an avulsion injury. So if we ask the player how much pain did you have when the injury actually happened, we can see that there was actually significantly higher pain at the injury moment in these avulsion injuries. But we can see that also these grades 0, 1, and 2 have quite a lot of pain as the injury occurs. So right there, this is probably not that clinically useful, and we even have players down in the lower grade which will give us a 10 out of 10, like it was really bad. But there is a trend towards a higher amount of pain, giving a more higher likelihood of an avulsion injury. Then when we get into the clinical examination and we ask them, okay, do you have any pain walking now? And we examine these players within 1 week after the injury. We can see that the lower grade injuries rarely ever have any pain on walking, where a lot of these players with an avulsion will have considerable pain still during walking. So that's definitely something that you can expect higher injury grade if they have pain during walking when they come into the clinical examination after the injury. And similar to other ligament injuries, if we hear a pop, is there potentially an avulsion or tear of the tendon? And we can see again higher proportion of injuries will players with an avulsion injury will say yes to that. Did hear a pop off. There's also cases where they don't. And strangely enough, even in grade 0 injuries, we have players that say they actually heard a pop. So again, not really clear, but again with a tendency towards a higher suspicion if they say these things. So we want to go over to our clinical examination. We know from previous studies that we did here that in acute adductor injuries, it's a little bit more easy to find the location of injury than for long-standing groin pain. If we just do our palpation, resistance, and stretch test, we have a really, really high accuracy in diagnosing an acute adductor injury correctly compared to an MRI. But we want to know a little bit more. We want to know how bad is it. And we did a study comparing the different tests to whether or not there was an avulsion. So we did something that's called a negative predictive value, meaning that if a test is negative, there will not be an avulsion. So you can start by ruling out a really serious injury. And you can do this with many tests. There are many of these tests which can help you in the clinical examination. If they don't have pain on a passive adductor stretch, very, very unlikely to have an injury. There's no palpation pain on the adductor longus insertion. Again, very unlikely to have an avulsion injury. And similar to the other tests here, if these tests are negative, then there's likely not an injury. So that's something that you can use to kind of rule out these more serious injuries and potentially save yourself some imaging. Where you have to be really suspicious and almost confident in an avulsion injury and diagnosing an avulsion injury is that if you feel a palpable defect, so a little nodule next to an insertion, often with a discontinuity of the tendon, you'd be able to feel that. And in all the cases where this finding was present, there was also an avulsion injury on the MRI. So really helpful in your clinical examination. Okay, so often we can do that. It's not all the cases that we see that we can actually feel this palpable defect. So if you're uncertain, rule out the injury, and if not, maybe go on with the imaging. And with the imaging, we can get a lot more details. But first, we got to know a little bit about the anatomy. So the groin area, especially in around the pubic symphysis, is something that clinicians are often very uncomfortable with. So I'll go through a bit of the literature here. And even experts, I think, still have a bit of disagreement on what goes on. But we know the adductor longus muscle here. We saw it earlier in the illustration we made. We have a proximal tendon that goes into the pubic bone up here, going further down, extending into the muscle. So it becomes an intramuscular tendon. And there'll be muscle fibers on both sides. So it doesn't have a free tendon such as other tendons, Achilles, patella, hamstrings, and so on. But the muscle fibers extend on the backside all the way up near the insertion. And we can see the insertion point here on the pubic bone. They knew that even back in 1976. A nice, really nice figure here. But we still talk a lot about this, or many people talk a lot about this rectus abdominis, adductor longus aponeurosis. Is that a thing? I think it's becoming more and more clear that it is not a thing. We have the rectus abdominis muscle extending down and inserting clearly here, as you can see, on the pubic bone, so the superior border. And we have the adductor longus with this initial, or with this separate insertion here below the pubic tubercle and medial to that. In the middle, we do have a bit of the rectus abdominis, so an internal tendon extending across across over the pubic symphysis, but separate from this adductor longus insertion. So we'd prefer not to refer to this area as the rectus abdominis adductor longus aponeurosis. There are other structures which crosses the pubic symphysis. We have here on the left the external oblique coming in across here and having fibers that extends across, often anterior also on the adductor longus muscle. And we have here in the middle, you see this little muscle in front of the rectus abdominis, which is called the pyramidalis, triangle muscle that sits in front here. And if you remove that, you can see the rectus abdominis muscle behind that inserting into the superior pubic bone here with just a tiny extension of the internal tendon across the pubic symphysis. But we have the adductor longus out here on the side, as you can see here on these images. Then we have an orthopedic surgeon who's dealing a lot with these avulsion injuries, Professor Ernest Schilders, who've now recently come up with specific types of avulsions based on the tears in this area and the connections in this area. And there are three key structures that you have to know. You have the pyramidalis muscle here, as we talked about before, the pectineus, which inserts a little bit more laterally here on the superior pubic rim next to the adductor longus, and the adductor longus tendon as it goes in and to the pubic bone here next to the pyramidalis in the middle. And based on these structures, there are 6 different types of avulsion injuries. Type 1 is a clear detachment, and is the most common one. So you can see here on the images, the proximal fibrocartilage of the adductor longus is detached from the pubic bone up here. And again here, missing from the sagittal images. Then type 2, we have a concomitant pectineus injury. You can see this little black line here being pulled off the pubic bone laterally to the adductor longus tendon. Same here in the illustration, so it's kind of like a curtain effect, pulling that off. So with the adductor longus completely avulsed and partially avulsion of the pectineus, and a complete discontinuity between the pyramidalis muscle here and the adductor longus muscle as it comes up here. Up here is the rectus abdominis, and often this has been interpreted as one muscle extending down here, but what we actually see on the images is the pyramidalis muscle here in the front. Type 3, we still have a connection between the pyramidalis and the adductor longus. So that means when the adductor longus is avulsed from the pubic bone, there are some structures here across, which is considered to be the pyramidalis muscle, attaching down to the adductor longus and ensuring that there's no considerable retraction, but it's more like an anterior displacement. On the other side here, we have the same with an anterior displacement, not too much of a distal retraction, but also with the concomitant pectineus injury. Type 5 is basically the same, also with the pectineus injury, but here a bit larger injury also to the pyramidalis muscle itself, a bit more proximally, not as common. And type 6 is actually what's the least extensive, which is just a partial avulsion, so a bit of hyperintensity here at the posterior part of the insertion of the adductor longus into the pubic bone, and no other concomitant injuries. So 6 different types. At the moment, we don't really know much about how these relate to treatment decisions and how these relate to prognosis, but I'm sure more will come in the near future from Professor Schilders. But now it's time to tell the player. We have our clinical examination, we have our MRI findings or ultrasound in most cases to confirm our clinical diagnosis. You're going to tell the player your muscle is off the bone. Boom. Imagine yourself being a player, football player, and a doctor tells you that your muscle is off the bone. What will go through your mind? It's very individual. People react to this message in different ways. Some of the most common thoughts probably, when can I play again for any type of injury? But for these serious injuries, can I play again? And how about my contract? How about my career? What am I going to do? This can create a lot of reactions in the player, which is really important to be aware of, and not only in the initial consultation, but also in the follow-up, especially as a physiotherapist as you're progressing with the rehabilitation, if that's the case. But in many cases, what will come out of the player's mouth is, can you put it back on? All right, your muscle is off. Can we put it back on? All right, we want to know that. So, of course you can. But is that the best option? So what are you gonna tell the player? Should you go straight for surgery, put the muscle back on, or should we try with an exercise-based treatment? So I'll go through a little bit about the different options. So the most common reason or comment related to surgery is that we're going to go in, we're going to restore the normal anatomy. So in these cases with adductor longus avulsions, we'll get some sutures through the tendon here, the avulsed tendon, fibrocartilage, and put that back into the pubic bone. Boom, we restored normal anatomy. Then following that, we'll do a post-op protocol. This is usually time-based. So we'll have a number of weeks in crutches. Here are 2 different rehabilitation protocols with 2 to 3 weeks in one, 4 weeks on crutches, 4 to 6 weeks just normal activities of daily living. And it's not until week 6 normally that players will be able to do strengthening, running, and progress with activities. So what about timelines? They follow this, pretty accurately. We have a study of 5 athletes here from the NFL, came back to return to play in 12 weeks. Another group of different athletes, they had 13 weeks, bit of variation, but no faster than 10 weeks. But relatively short period of around 3 months. And then we have one study here, which was a little bit more conservative, I think, in their approach. It's not that clear, but almost 5 months after surgical treatment on average. Okay, so we have some pretty clear timelines, some pretty clear guidelines as well. So how does it look with the exercise-based treatment protocols? In most cases, these will actually follow the post-op protocols as well. So in this study from Germany, there are 6 weeks of passive mobilization and cycling as well before they went into linear running and strengthening exercises. So if you use this time-based approach, a little in the beginning, and then not until 6 weeks after we can actually start doing some proper training. And what will that give us in these 6 athletes? It's about the same time period, naturally, because we're looking at plus 10 weeks for return to sport. That's what it says here. On average, they had 89 days of return to sport, and there wasn't that large variation between the players in this cohort, or in this case series. But there's a difference between doing these time-based rehabilitation protocols versus criteria-based progression protocols. I coincidentally have a player right now with an acute adductor longus avulsions who gave me permission to share his images. So these videos are from this week. So he had a right complete adductor longus avulsion just 2 weeks ago. And you can see he's already at a very, very high level. So this is 2 weeks after. He's already doing change direction. Here in this drill over here, he's actually pain-free at around 70-80% of relative intensity. Here also around 80% intensity, with only 1 to 2 out of 10 pain in some of the corners. And that's it. So they can do a lot more than what we think they can do. And this is generally how we approach acute adductor injuries here at Aspetar. We had a study out in the beginning of the year with our protocol, where we kind of block the groin exercises on one day, non-groin exercises on the other day, focusing more on the posterior chain muscles, but then with a running and sports function progression from the early stages. So kind of 3 strands of progression that will follow continuously, and you can read more about the specific protocol in Orthopedic Journal of Sports Medicine, which is open access. And I'm happy to talk more about that another time. Our study finished 3 years ago with inclusions, and we're still kind of using the same approach, although not as strictly, using our experience as well to kind of optimize the treatment, but it follows the same principles. What we want to do is we want to isolate the painful structures. So we want to make sure that we're tracking the capacity, that we're training the individual injured muscle and assisting it in healing rather than allowing it a healing, but also testing the capacity when it's isolated. We want to focus on the synergist and the painful movements, and we know there are many potential at-risk moments, as we talked about before. So then we're generally looking at a full body approach, focusing mainly on muscle groups involved in change direction and kicking. And we want to progress actual required functions. So we want to get them running, we want to get them out on the pitch when we can. And we'll do some general training as well. So when can you start running? I mean, it varies a lot. Here's an exceptional example, also with right complete adductor longus avulsion. We'll get him on the ladder drill and check their ability. Here he's doing a shuffle drill from side to side. So if we start with a very limited range of motion, we still in this exercise don't even get into hip extension. We have a very limited hip abduction as well. So they can actually often do a lot more than you think. A good advice is also to get them on the bike. Initially when they come in, often when they have pain when walking, as we see they often have during the first week, just getting on a bike and do about 10-15 minutes warm up on a bike on the first session will make their walking immediately better. But we can use this as soon. So this guy is not able to jog, he's not able to run, but at least he can start moving a bit, and we can progress as soon as he's able to do these ladder drills. He'll get walking, and he did so already get jogging, and he did so within a week already. Then when are you ready to return to sport? We've had some pretty strict criteria for that as well. So we had different return to sport milestones. Clinically pain-free is one of the key criteria, has been one of the key criteria before we let them out on the pitch, where they will then do controlled sports training, or if it's a different sport, so they'll be inside. So the clinical pain-free criteria is very, very strict actually. They cannot have any pain on palpation, on maximal isometric adduction, stretching, a couple of strength exercises, and running, and a bit of change direction as well. So they're really pain-free. So this criteria would be similar to if you get a player into your clinic and you wouldn't be able to detect that player has an injury at all, except from the history. So quite strict before we go over to the football training at a higher intensity. And our results here in a cohort of 16 athletes, 15 athletes, we lost one in follow-up, were that these players were clinically pain-free in 55 days. So around 2 months to be completely pain-free as a median, and they completed all the sport-specific training and were allowed back into the team after just over 2 months. Then the team took a little bit longer to put them into full team training, but we're looking at here 2 to 3 months. So slightly faster than the other studies, the other study with the rehabilitation protocol and the surgical treatment, but also look at the variation here. With this approach, you're really allowing this individual progression to occur a lot faster in the cases that this can be done. In the NFL, they seem to be a bit more progressive, although this study comparing players retrospectively receiving a non-surgical treatment and surgical treatment didn't describe the rehabilitation protocols involved and what other criteria there were from returning to play, but the players returned really fast. So 6 weeks for these 14 players who received a non-surgical treatment, and 12 weeks on average for the 5 players that had a surgical treatment. But the good news here is that all players return to play, and that's something that we see basically throughout, regardless of the intervention. So as a physio, we want to do some clinical measures as well. So we did that during the rehab. We took daily clinical measures of palpation pain, flexibility, and strength. And we have a lot of measures, as you can see here. Each little dot here is a measurement point We have the rehabilitation progression in percent, so 100% is when they complete it, and we're completely pain-free over here, and that's relative, so it's in percent, and that's around 2 to 3 months, as we remember, around 2 months. And on the y-axis here, we have the extent of palpation pain here, the length, and the width of the palpation pain, which we measured. And we can see already around the halfway through the progression of rehabilitation, the majority of players will only have pain in a very small area located at the insertion. But also that this, both in terms of length and width, it's very localized to the insertion. But that this pain actually remains for quite a long time. So there is probably the potential that if we don't want to wait completely until the players are completely pain-free on palpation, that you can progress a bit sooner, possibly with a bit higher risk, but I think there's potential for even a sooner progression into sports training, regardless of whether there's a bit of remaining palpation pain. We're looking at our hip range of motion, so adductor flexibility. In a side-lying test here with an inclinometer, we measured that. Initially quite reduced for many of the players, but that flexibility quickly goes back around normal and follows that individual flexibility in the players for the majority of the rehabilitation. Here in the end, they had almost clear symmetry, what we consider symmetry, for their hip abduction range of motion. So that's not really a concern in these players. In general, not something we need to worry about. Similar for the bent knee fallout, an initial reduction here in symmetry, and that's mainly related to the pain. But as soon as the pain drops, they will also regain their normal symmetry. We also did strength test, and what we can see here is naturally they're not able to push much in the beginning, highly reduced, and some players are of course not even able to perform the test. But they also relatively quickly, around halfway through, get closer and closer to symmetry. And what we found here is that in the end of the treatment, our players still had a slight reduction of strength on the injured side compared to the uninjured side. So there's definitely something to take with you. This was not part of our criteria, but it's important to remember that they probably haven't regained full strength once they meet the criteria we set out for them. So it's something that they should definitely be working with further on, in our opinion. But we can also see that on average, they have normal values, so comparable to what we see in the cohort of football players here in Qatar. So average values at return to sport as in uninjured players. But what happens after return to sport? What about re-injuries? What about their status? Are they happy with the treatment? So in our cohort, unfortunately, we had one re-injury shortly after the players returned to sport. He was kicking a ball and felt some acute pain again. There wasn't anything to see on the imaging, but at least he was still out for another month. So the rehabilitation was extended for another month. The rest of the athletes, no injuries at all. Similar for the NFL, for the two different German studies that has followed up after return to sport. They all report no re-injuries. For the surgical treatment, there are not that many complications, serious complications, 2 minor complications, whereof one actually required a minor surgery. Again, it didn't extend the rehabilitation that long. It's not completely clear, but no clear re-injuries were described in these studies. If we're looking at patient-reported outcome measures, here's a study from one institution where they compared 2 groups that had received received either a non-surgical approach or a surgical approach. And we can see they use different types of patient-reported outcome measures. The modified Harris hip score, hip outcome score on activities of daily living, and sport-specific hip outcome score, level of sports here. We can see these are all individual players, but maximum scores here, 68, and 36 here is the maximum score. So in both groups, they're doing really, really well, and there was no difference between the two groups. So excellent results. If we're looking at the 15 athletes that we were able to follow up a year after return to sport, we used the hip and groin outcome score, which has different subscales, and on average they had the top score of 100 with some smaller variations in some of the subscales. But again, excellent results from the patients themselves and how they perceive their symptoms and function. And similarly, another surgical study on 6 players with around 1.5 years follow-up after an avulsion, also using the same scales as the other surgical study with a modified Harris hip score, the hip outcome score of activities of daily living and sport specific. We can see close to top scores in these 6 players, despite a few of them still having quite considerable pain. A couple of these guys, but as an overall, quite excellent results. So we did a bit more here in Aspetar. We got them in and we did both a clinical examination and an MRI. I'll start with a clinical examination, mainly pain-free. For the flexibility, we can see that the flexibility remained the same with around 100% symmetry. For strength, a year after, the same test as we did before, they still had a slight reduction on the left side. So we were not in control of their adductor training or their training in general after they left the hospital. But we can see that the players that we followed up on still have a minor reduction in adductor strength. We did a similar test, but in outer range. So also an eccentric strength test in a position that we think is more relevant for injuries. And there was also still a slight reduction compared to the uninjured leg. So definitely something to consider and continue to monitor throughout. We looked at the MRIs, and so here's a picture of a clear avulsion, as you see it here, and the pubic bone up here. And about 2 centimeters retraction in this case. And then we did an MRI when they returned to sport, and we can see that it's still not healed. We still have this this retracted proximal tendon, but we can also see these lines of hypointensity, which indicates that there's some fibrosis ongoing here. And then when we had the follow-up here, 1 year follow-up, a little bit more than a year for this player, we have a continuous tendon all the way up to the bone. You can see it's a lot thicker than the other one, so you could consider this potentially being stronger as well. But this is just to say that the body is quite amazing by itself, and often it probably does not need somebody else to restore the normal anatomy, but does pretty well by itself. This is not all cases that look like this, though. The most typical appearance at the 1 year follow-up was this. So we still have a continuous tendon, or the retracted area, kind of scarred up, as you can say. But with a little bit of hyperintensity just at the insertion. And it's something that we see also in asymptomatic players, and it's been related to long-standing groin pain as well. But in this case, no pain, no palpation pain, but still with probably an ongoing healing, we can call that. So it'd be interesting to see in a bit longer follow-up. And for the MRI, we just submitted this case series of adductor longus avulsions. What we can see that from the tendon continuity, they all started out having a complete discontinuity, so a complete avulsion already when they're back, and there's some that still has this complete continuity, but the majority are showing signs of healing. And on the 1-year follow-up, we can see that there's already a partial attachment for all of the players that we were able to get an MRI on, and in some cases with tendon continuity. And this partial discontinuity is very minimal. We can see the direct tendon retraction now is down to 2 millimeters, which just indicates this little white hyperintensity that we saw in the other image, and minimal displacement. And for the avulsion types, we scored those as well. We can see that we didn't have all the types included in our study, but the most common was these clear avulsions, potentially involving the pectineus as well in many cases. But over time, these types turned into what we would say a partial avulsion, or being so good that they would not be able to be categorized into a type. So to summarize, if this happens to you or to your player, you can diagnose most of these cases clinically. There's some clear tests that can show you that there's an avulsion. If there's a palpable defect, you have to suspect an avulsion. Down here, and if there's no avulsion, there are certain tests that can we fix the sound? That can rule out these avulsions. We have some very interesting information on the MRI, so you can get a much clearer picture of the different structures that may be involved in these injuries, which vary a bit, but it's still unclear how much they matter. And in our cohort, we showed that they probably do not matter that much when we're choosing an exercise-based approach, and that at 1 year they all do well regardless of the ones we had in. For the treatment, this is the best news for the players. There's great return to sport rates regardless of which approach that you do. If you take a surgical, you take a non-surgical approach, you're very likely to return to sport at the same level as you were before. What we know is that exercise-based treatment is usually a bit faster. So what we usually say here is around 2 to 3 months if you want to do rehabilitation. If you want to do surgical treatment, you're probably looking at 3 to 4 months. But regardless of which treatment you choose, the 1 year status and a little bit longer appears to be excellent. So good news, not as bad as it could be. In the end, I just want to say thank you for everybody who's been part of the Aspetar Sports Groin Pain Center from the beginning when I came till now, and everybody around in the hospital who's really been key in making this a pleasant time. And I think not only is it a good time being here, interesting working with the patients together across disciplines, but I think as a groin pain center, we actually already had quite a considerable influence on the literature and management of groin pain patients around the world today. I would just want to highlight that we got another little presentation or symposium on groin pain here coming up on the 6th of January as part of the Aspetar Sports Medicine collection. So put that in your calendar. It's an evening session. And in the beginning of the new year, we'll have Willem Heibor, who's our PhD candidate here at Aspetar. He will be doing a Tuesday lecture on diagnosis of long-standing groin pain. So look out for that as well. So thank you very much, and I'll be happy to take some questions.